So let's start talking about the various anticoagulant drugs, starting with heparin. Heparin is administered either via the intravenous route or via the subcutaneous route. It is not given orally simply because it is too large of a molecule to be absorbed in that particular manner. So what is the mechanism of action of heparin? We know that heparin is an anticoagulant and therefore in some manner it interferes with the coagulation cascade. But what about the mechanism? So heparin, which is a molecule that is administered to a patient with the intent of enhancing anticoagulation, this molecule enters the body via the IV route or via the subcutaneous route, and after entering the body, it binds with something known as antithrombin 3. The thing to understand is that antithrombin 3 is a natural anticoagulant found in the human body. When it is bound to by heparin, its anticoagulant effect is dramatically enhanced, and this is the mechanism of action of heparin, the fact that it potentiates the effect of an anticoagulant molecule already present in the body. So which clotting factors are affected by the action of heparin? Thrombin, which is considered to be factor 2, as well as factor 10, which in Roman is written as factor X. So factor 10 and factor 2 are affected. Heparin comes in two forms. There is something known as high molecular weight heparin, which is also called my apologies. There are two types of heparin. There is high molecular weight heparin and there is low molecular weight heparin. Low molecular weight heparin is basically acquired via modification and processing of unfractionated heparin. Unfractionated heparin, on the other hand, contains both high molecular weight and low molecular weight heparin of varying sizes. So we need to compare the high molecular weight heparin and the low molecular weight heparin. The high molecular weight heparin, which is found in the unfractionated heparin, will inhibit both factor 10 as well as thrombin. इन्हीं दोनों factors पर effect होगा high molecular weight heparin का, which is found naturally in unfractionated heparin. But low molecular weight heparin, on the other hand, which we get via processing of unfractionated heparin, only has an effect on factor 10. And the reason for this is that during modification and during shortening, a particular part of it is removed, which is necessary in order for the molecule to be able to bind to and inhibit thrombin, which is factor 2. So these are some important points as far as the pharmacology is concerned. And now we have another molecule, which is fondaparinux. I'm not sure if this is the way to pronounce it. This is a synthetic analog, meaning we made it. It was not acquired from a natural source. Now this is a molecule which closely resembles low molecular weight heparin and has similar biochemical properties in that it does have an effect on factor 10 but does not have any effect on thrombin, just like low molecular weight heparin. The point to remember is that this synthetic analog has once daily dosing, so it is good as far as compliance is concerned. So what is the clinical use of heparin? One thing to remember is heparin and acute anticoagulation. When anticoagulation is needed promptly, that is when heparin is used. So what can be the conditions? A prompt treatment of deep venous thrombosis, which might be threatening the viability of a limb. Pulmonary embolism, which might be fatal if not taken care of. And MI, which if not taken care of could lead to extensive damage to the heart and finally death. So these are some of the conditions in which you can use heparin for its acute anticoagulation effects in the treatment of DVT, in the treatment of pulmonary embolism, and in the treatment of MI. We can use heparin in combination with some other drugs. For example, it is often used. So it's used in combination with a set of drugs known as the GP2B3 inhibitors, and these are not anticoagulant drugs. These are in the class of the antiplatelet drugs, and I will tell you the difference later. And for what purpose is heparin combined with the GP2B3 inhibitors? During angioplasty and the placement of a stent. Obviously, angioplasty is something which is carried out in a person who has had an MI because of a certain thrombosis. So you basically get rid of that thrombosis which is formed in order for you to be able to place a stent. So whenever a patient comes to you with an MI, generally the first choice is to perform an angioplasty, but if that is not a possibility, the second best option is to promptly give thrombolytics, which we will discuss later. So it is given with the GP2B3 inhibitors for angioplasty following an MI for the sake of reperfusion. It is also given in combination with thrombolytics for revascularization following an MI. So there are two ways of dealing with an MI promptly, either by thrombolytic use, which is the medication, or via angioplasty. And in both of these, heparin has its role to play, right? In the case of angioplasty, it is given with antiplatelet drugs to make the process easier, and it is also given with thrombolytics to lyse the thrombus which might have formed in a critical coronary artery. So does heparin need monitoring? It does, because sometimes the anticoagulant effect might become too much. And how is this monitoring achieved? Via APTT pathway or APTT basically test. Do we need it? For low molecular weight heparin, we do not. We only need this for the unfractionated heparin. We do not need monitoring for low molecular weight heparin, and this is one of the advantages of using low molecular weight heparin, the fact that you do not need to carry out therapeutic monitoring of the plasma levels. There are a couple of other benefits to the fact that low molecular weight heparin has better bioavailability, about 4 times more bioavailability compared to the unfractionated, unprocessed form. So what happens if too much heparin is given accidentally? For example, if it was unfractionated heparin and therapeutic monitoring was not carried out properly, and there was overdose of heparin and there was over anticoagulation, what would you do? You would basically prescribe protamine sulfate, which is a molecule you might have already encountered in general pharmacology, because this is an example of chemical antagonism. The protein sulfate, which after getting administered will react with the heparin to form a molecule that does not have anticoagulant effect and which can be removed from the body. This is what is meant by chemical antagonism. It is more effective against unfractionated heparin, less effective against low molecular weight heparin, and has absolutely no effect against the synthetic analog. So if the synthetic analog is given in too much amount, this antidote will not have any effect. What about toxicity? Obviously bleeding, which is a potential toxicity of pretty much every anticoagulant. There's something known as heparin induced thrombocytopenia, which is actually a hypersensitivity reaction. It is an immunogenic reaction basically. So how do you deal with that? Obviously, first of all, you immediately stop giving heparin, and you basically shift to another anticoagulant which can be used as a heparin alternative, which will have acute anticoagulation without having the immunogenicity of a heparin molecule. And oftentimes you go with direct thrombin inhibitors. Notice, as you can tell from the name, heparin and direct thrombin inhibitors have the same substrate. So it does make sense that it is the alternative that we most usually go with when we discontinue heparin administration in favor of another drug because of HIT. So 2 examples of direct thrombin inhibitors which we can use when there is an episode of HIT argatroban, and bivalirudin. Another thing is that prolonged use of unfractionated heparin is associated with osteoporosis. There is another benefit of using low molecular weight heparin, which is processed heparin, because it is not associated with an increased risk of osteoporosis, whereas unfractionated heparin is indeed associated with that. So, couple of benefits of low molecular weight heparin over unfractionated. There is no need for therapeutic monitoring. You don't need to monitor the APTT. The bioavailability is better, and there is also actually reduced risk of HIT, and there is no associated risk of osteoporosis because of chronic use. So we're done with heparin. We can talk about warfarin, and the reason we are talking about this immediately after this is because warfarin is very important and is used for chronic anticoagulation. So the indications will be different, but will also be same in certain areas. How do you think warfarin operates? It basically inhibits an enzyme which is important for the recycling of vitamin K. And in the absence of vitamin K, the vitamin K dependent clotting factors like factor 7, 9, 2 and 10, these are the 4 vitamin K dependent factors, they are not produced. Do we need to monitor warfarin? Yes, we do, using prothrombin time, using INR. The thing is that actually warfarin is having an effect on both the intrinsic and the extrinsic pathway, yet we are only monitoring prothrombin time, which is used to monitor the extrinsic pathway. The reason for that is that of the 4 clotting factors whose levels are dropped, the levels of factor 7 drop first, and therefore it is a better idea to basically modulate or to basically monitor the prothrombin time. So what do you think is the antidote in case too much warfarin is given? Obviously you give vitamin K for an immediate effect, because even if you stop even if you stop warfarin, it will take a lot of time for the clotting factors which are vitamin K to be reinstituted, at least 7 hours, because factor 7 is the first one to reappear in the blood after warfarin therapy is stopped, but it still takes many hours. So you need to give vitamin K promptly, because that is the substrate whose availability is stopped because of the use of warfarin. The second thing is to give fresh frozen plasma immediately, because even when you give vitamin K, it will still take time for the clotting factors to get produced. Up to 5 to 6 hours for the clotting factors to be produced. Synthesis takes time. There's transcription, translation, then modification. It will take time for the clotting factors to be produced after you give the vitamin K which was missing. But you need to stop the bleeding right now, so you give fresh frozen plasma which already contains those clotting factors. Side effects: same, bleeding like any other anticoagulant. Very important, warfarin is teratogenic. It is contraindicated in pregnancy, absolutely contraindicated, which is why heparin is the drug of choice for anticoagulation in a pregnant individual. Warfarin has some very important drug interactions which you probably already know about from your knowledge of general pharmacology and from the number of times this drug would have been repeated as you would have been doing special pharmacology. ठीक है, जो P450 inducers हैं उनकी वजह से clotting time कम होता है because of the anticoagulation. This is interesting, right? Inducers की वजह से तो metabolism बढ़ना चाहिए. जब वो मेटाबॉलिज्म बढ़ना चाहिए तो INR को बढ़ना चाहिए, बट दैट इज़ नॉट ट्रू. P450 इंड्यूसेस की वजह से INR विच इज़ अ प्रोथ्रोम्बिन टाइम वो कम होता है. समथिंग टू कीप इन माइंड. एक और बात यह है, वॉरफरिन की ना बहुत ही स्ट्रॉन्ग और एक्सटेंसिव किस्म की प्लाज्मा प्रोटीन बाइंडिंग होती है, लेकिन वीक भी होती है. बहुत ज़्यादा वॉरफरिन देते हैं, उसमें 99% प्लाज्मा के साथ लग जाता है, सिर्फ 1% काम कर रहा होता है. बट अगर आपने साथ कोई और ड्रग दी जिसकी बहुत स्ट्रॉन्ग किस्म की प्लाज्मा प्रोटीन बाइंडिंग है, तो इट विल बेसिकली किक वॉरफरिन आउट ऑफ द वे एंड गेट बाउंड टू द सेम साइट्स ऑन द प्लाज्मा प्रोटीन. कहने का ये मतलब है कि इसकी वजह से वॉरफरिन के लेवल्स बहुत बढ़ जाएंगे एंड दैट कैन हैव टॉक्सिक इफेक्ट्स. तो प्लाज्मा प्रोटीन बाइंडिंग भी एक ऐसी प्रॉपर्टी है जिसको जहन में रखना अहम है. ठीक है, जब आप वॉरफरिन थेरेपी स्टार्ट करते हैं ना, फॉर द फर्स्ट कपल ऑफ डेज आप साथ में हेपेरिन ज़रूर देते हैं. अदरवाइज देयर माइट बी ए टॉक्सिक इफेक्ट नोन एज स्किन नेक्रोसिस। उसकी क्या वजह है? वॉरफरिन का असर आने में कुछ टाइम लगता है, बिकॉज इवन इफ वॉरफरिन ने एकदम से विटामिन के की लैक ऑफ अवेलेबिलिटी क्रिएट किया है, जो पहले से क्लॉटिंग फैक्टर्स हैं वो भी काम कर रहे हैं, इट विल टेक टाइम फॉर दोज टू गेट डिस्ट्रॉयड, जैसे कि उनकी हाफ लाइफ गुजरती है। उस दौरान में अदर देन विटामिन के एंजाइम प्रोटीन सी एंड प्रोटीन एस, वो एंटीकोएगुलेंट्स होते हैं, उनकी भी इनहिबिशन होती है। तो जब वो उनका काम ख़त्म हो गया, कोएगुलेशन बढ़ गया है एंड क्लॉटिंग फैक्टर्स भी अभी ख़त्म नहीं हुए, तो हाइपर कोएगुलेशन की वजह से निक्रोसिस हो जाती है। विच इज़ वाई ऑलवेज जब आप वॉरफरिन देते हैं ना किसी भी क्रॉनिक एलिमेंट में, क्रॉनिक एंटीकोएगुलेशन के मकसद से आपने शुरू के कुछ दिन हेपरिन ज़रूर देनी होती है। तो ये हमने कुछ बहुत ही अहम किस्म की बातों को डिस्कस किया।